agenda today? Okay. So I guess that goes to our start of our education session with Mr. John Stevens. Thank you for coming.
Thank you for having me. So I'll quickly introduce myself in case you don't know who I am. My name is Misty Stevens. I'm a wound ostomy continence nurse. So I've been specialized for about 17 years. I have my master's of wound healing from Western University. I've been a nurse for 24 years, started my career in California, moved up here 20 years ago. I was a medevac search and rescue nurse first, and then I had 3 babies. And I needed to kind of even out my career and work Monday to Friday. So I became a wound care nurse. I love educating. I love educating nurses, and I love educating physicians, and I work for Bladder Cancer Canada, as well as the Bladder Cancer Supportive Care Program, because I'm an expert in urinary divergence. And I also work for the University of Victoria, teaching their nurses program. So I'm busy, but I love it. I don't actually, it's all done online. So I teach specific programs. So I teach the continence program in the geriatrics. And then I also teach wound care for clients experiencing inequities, which is our advancing population. I teach nurses how to use everyday products like toothpaste and mouthwash and all that kind of stuff that they can find on the side of the road in order to treat the people that live on the side of the road. And then I teach the wound management to all of our LI counts. And it's all done online, so I don't have to work.
So we're lucky.
I don't know.
Here.
I don't know. Well, wait and see what you think. We want to. We can go left and right.
Let's see. No.
I use the arrows. Here. As looking at the first slide though. All right. Okay. So I'll quickly go through, so just our objectives. I'm going to review the common etiology. What we use as our wound management guide, which is Hold the Dime, and it was written by Dr. Sibold and Dr. Wu. And then review some of the recommended products that we have in Fraser Health. So I do work for Fraser Health. I work in Fraser-North, which is from Burnaby to Maple Ridge. Here is this document. I think that most of you might be familiar with it, but then again, some of our DOCs as well as our nurses aren't familiar with it. The Ministry of Health created a document that was made for home and community care that said, this is what has to be provided to each one of our owned and operated as well as affiliated residents. Within that, they came to our provincial skin and wound committee, and I happen to be chair of that committee, and they asked us to create a document that every single long-term care site has to have in stock. So the first 2 columns are going to be the products that the long-term care sites have to have in stock all the time to be used on their residents. On the 3rd column is one that they have to bring in within 1 to 2 days. Fraser Health will provide those products for the first few days, and then it is something that the long-term care sites have to bring in. Anything that ends WOCS, nurses specializing in wound ostomy continence, recommend to be placed on a resident that is not on this list, then Fraser Health will provide it if they are in funded beds. If they are in non-funded beds in private care, then home health can come in and provide them. So it'll still be Fraser Health products. It's just a different way of getting them. So in this product list, I'm going to go through all of the dressings that are in that 1st and 2nd column. So you guys understand what those dressings are used for as we go through this present. So dime is what nurses, stand up. They don't sit very well. Dime is what nurses use in order to do wound management. First, we always look at the person. We don't want to look at just that hole in the person because that's not treating the wound. So identify the cause. And then we go to the local wound care. And the wound care stands for debridement, infection, inflammation, and moisture balance, and then edge of the wound. Always looking at the person-centered concerns. Why? Because my goal for their wound healing may not always be what their goal for the wound healing is. So as we move through this dime, we're looking at the wound to find out which products we're going to be using on that wound itself. So Usually we start with debridement because it probably has non-viable texture. So debridement options that we have that are on that list on your first 1 and 2 columns. For autolytic debridement is the removal of necrotic debris and devitalized tissues from a wound through a moist environment that facilitates the body's own endogenous enzymes. We can promote this by using wound care products that will promote the autolytic debridement. These are ones that they should have on hand all the time. What's really important is to make sure that you are protecting the peri-wound skin, because these are going to make a hot, mucky mess. And we know that they're going to have to change the dressings every single day, but they're very effective. With most of these wounds, you will see that devitalized tissue debrided within 7 to 14 days. So this one here is called Intercyte. It is just a hydrogel. All it is water in a gel form. So really safe, easy to use, no pain whatsoever. Triad is hydrophilic, so increase the water content inside the wound bed. And has a debrider in it. It also has zinc oxide in it, so it can be used in the fridge, which is really comfortable. What I see nurses doing is putting it on the peri-wound skin. It does eat away at epithelium because it does have a debrider in it. So that's the only cautionary that I have for the Triad. Really, really good for like coccyx wounds, because if you have stool or urinary incontinence, that will keep it out of the wound bed. Honey is good for any kind of wound that you are suspecting some kind of infection. Really great at treating pseudomonas. It's a gel format. We have it in 2 other formats as well. It's a sheet as well as an apponate. But this is great for debriding because it's going to promote your autolytic. But very, very messy and smelly when it goes to the debriding.
Nurses are thought, buying Triad cream for the.
Peri-wound skin.
Well, they're just saying Triad cream, it's not necessarily this, or is all.
It is this.
So that's.
So this is a concern.
So they're putting it on under like a breast wrap or underneath over to.
Yeah, that doesn't belong there. So
What if there's no skin in that?
it's gotta be down to the dermis. If there's still epithelium there, it is not meant for this. The confusion with nurses, because of the fact that you turn this over, it says zinc oxide. And we know that zinc oxide is meant to be treating skin care. This is, and it says right on it, and I have to remind nurses, wound dressing. It is for wounds that have depth, which go down to the dermis. If it is just the epidermis with superficial openings, then it's skin care. And this is not the right product. They should be using, if it's skincare issues, so superficial openings, they should be using a zinc oxide that has 18 to 30%. Extra Protective Cream by Smith & Nephew has 30%. Remedy Medline, which most of our affiliated sites are contracted to, it has 18%. So they can be using either one of those for skincare, but not Triad. Triad, they're doing more harm with. Today, I saw a gentleman that has had moisture-associated skin damage, severe, it's purple around his butt cheeks, and they've been applying Triad for months. And unfortunately, now it's all opening and they've created an environment for pressure injuries.
Yeah.
And all I had to do was stop the Triad and say, put a condom catheter on. That's my other pet peeve is diapers. Don't agree with them. You probably know. The other form of debridement, so autolytic debridement, is something that nurses can do without physician's orders. So every time they want to facilitate some kind of debridement of non-viable tissue, they can start one of these without physician's orders. The other one that they can do is mechanical debridement. This should be done every single time they clean a wound. So mechanical debridement is a non-selective type of debridement, meaning that it will remove both devitalized tissue and debris and viable tissue. However, research base knows that irrigation is the safest, gentlest, easiest way of doing that. We have when I say we, I mean BC Provincial Nursing Group. We know that 30 cc syringe and a soft tip catheter, which is 15 centimeters, produces a PSI of 8 to 15. That is the optimal PSI for any kind of wound irrigation that will create mechanical debridement. We encourage the nurses to do this with any and all wounds. It is the safest, easiest way to debride and clean a wound. It has to be those 2 specific things. It needs to be a 15 centimeter soft cannula and it needs to be a 30 cc syringe. The other thing that I always tell nurses to do. 15 centimeters. The other thing I tell them to do is not be afraid of the wound. I will get my gauze in there and I will scrub that wound head. It needs to be cleaned. If we're patting it on the head by just dabbing it with a little bit of saline, we're not cleaning that wound. We know that wounds will heal if we clean them properly without a whole lot of expensive products a lot of the time. Sometimes we need the expensive products, but a lot of times we don't. The two other things that we have on hand that nurses are going to be very familiar with is knee salt. Knee salt is just a salt impregnated dressing. It's incredibly cheap. Also comes in a ribbon, needs to be changed every single day. That's the only drawback. Now, the other thing that I really like about knee salt is it's great for treating hypergranulations. So a lot of times when hypergranulation around a trach or around a G-tube, around an ostomy, we tend to lean towards our AgNO3 or silver nitrate. But for long-term management, all you have to do is fenestrate a knee salt, change it every single day, and those granulations will go away. The other part that we have is called Hydroferro Blue. This one's going to be a lot more expensive. Now, Hydroferro Blue is a very, very strong antimicrobial. It has Genesian violet and methylated blue in it. And if you know anything about those two products, Genesian violet has been used in Asian countries, Philippines, for a really long time for treating wounds that they feel are infected. Methylated blue is a dye that we used to use in surgery. When I first started, we used to insert it into the abdomen to see whether or not we have fistulas. What we've learned, unfortunately, is that both of those things are carcinogenic. However, we can use them in wound care because it doesn't deliver either of those into the wound bed. So it draws out, it's got a wicking feature in that PVC foam, and it draws it up into the dressing and kills the bacteria in that dressing. It also has anti-inflammatory effect, and one of the only dressings that can treat PG, hypodermic gangrenosis. So the other pieces of debridement are enzymatic, which has to have a physician's order attached. What a lot of physicians don't realize is that Santyl, that little tube there, is about $200. If they're in acute care, that cost is covered. Nowhere else is covered. So we often suggest that we don't use Santyl just because of the cost. The other thing that we don't encourage for is that you need to have oxygen in the wound bed. It is a live enzyme in that dressing. And if you don't have oxygen in there, it will pull the oxygen from the tissues and can create a necrotic tissue. So you have to be careful with Santyl. It also needs measurements to know how much to put into the wound bed. And the nurses are not always quite diligent to be putting enough. So if that's not the case, then sometimes we're wasting that very expensive dressing. And then last but not least is maggots. Like I said, we used to put maggots on wounds all the time up until the new administration in the United States, because our medical grade maggots came up from California. We used to bring them over the border all the time. Now he has stopped that, so we don't have them. However, we have what I call community acquired maggots, ones that come into us. They are very good at debriding. Often we see that they are still the green bottlefly, and they will only go after the non-viable tissue and will leave the healthy tissue open. Incredibly effective way of debriding wounds. You have a diabetic foot that can be debrided within 24 hours or even 48 hours without them having to go to the OR. It really depends if you're using the right amount. You have to change it every single day, but you're looking at probably 7 to 14 days, the same as the other products in the autolytic debridement. So the cost difference.
This over different methods?
The only place I ever see this being used is a lot of our vascular surgeons like to use it. I haven't seen a benefit over some of the other ones. I think it's just as effective to use the autolytic debriders. So wound healing. So then you'll notice that nurses categorize wounds based on their goals of care. So our goals of care are going to be healable, maintenance, or non-healable. So when we look at a healable wound, we're looking at is it decreasing in size after debridement of the necrotic tissue by about 20 to 40% in 2 to 4 weeks. If it is not, then we're going to consider it a maintenance wound. That doesn't mean that it's not going to heal. It's just going to heal slower than what our normal healing trajectory is. So, for example, if you have a pressure injury on the heel, and we encourage you to paint it with povidone iodine, it's not going to follow a normal healing trajectory of that healing time. And so we're going to make it a maintenance wound. Doesn't mean it's not healable, it just means it's going to be slow to heal. Non-healable is usually reserved for our arterial wounds and our malignant wounds.
So you decided before that it's not going to be a healable wound, but it's, as you're saying, it's the iodine.
Yeah.
Oh,
Yeah, so it was probably a non-healing wound, so a maintenance wound. A lot of our arterial wounds, it's just safer to eat it than it is to get it wet and mucky and have the bacteria come into it. So these are just, I'm just gonna go through the dressings that are on this list here so that you guys understand what they're used for and why we use them. So our jelly fibers are lovely little seaweed fibers. This product here does come in woven, so you can actually cut it into strips or into spirals, and it can be packed into wounds or it can be placed onto wounds. What a jelly fiber means is that it's extremely moisture retentive, so it will pull the moisture from the wounds and then hold it into this gelling fiber that then goes from a fiber into a gel. So then you have a moist wound environment, which is what we want for healable wounds. We want moisture in there so that we can move those epitheliums around. Next, we have calcium alginate. Again, another one that's made with seaweed. This one is used for bleeding wounds. So this one's called Calcisat. As long as it's a minor bleed, so you have a short little trickle, then this will help heal that up. The only problem that I have with this one is that if you leave it on the wound bed too long and there's not enough moisture, it is going to become like concrete on that wound and very difficult to remove. So just make sure that you have enough moisture in that wound bed. Then we have the acrylic dressing. This is our gold standard for treating skin tears. It has an acrylic pad right in the center, and along the edge is a transparent film, which is like Tegaderm. That little acrylic pad will absorb moisture, create a dome so that you have a moist wound healing environment, and then it evaporates the excess. So as long as you're not overwhelming the dressing, that dressing can stay in place for 21 days. So we often tell nurses to just put the date on it and then leave it in place. They don't want to see it change as often every single week or anything like that. It should never be changed.
What do you mean by overwhelming dressing?
If there's too much exudate, so if the exudate is too high of a volume, it will just leak out. Yeah, so I don't like them on lower limbs because of the fact that lower limbs are going to have edema and probably leaks with that dressing. But on arms and bodies, it's usually the best thing to use. It also goes really great around an elbow. It's very fun.
So just on the skin there, you put something like that on.
Skin tear, laceration, trauma. Yeah. As long as, like I said, they don't have a whole lot of bleeding or a whole lot of exudate.
Could we use that when people get lacerations then? You know, like I opt not to send them to emerge.
Yeah.
But they've got a laceration, because I'll just tell the nurse, well, just put it together as best you can and put a wound dressing on it.
Yeah.
But that almost sounds like,
Fine, if it is bleeding, I use a little strip of calcium and then not over top of it, and then change it in 7 days. Yeah. Our silicone, so we use methyl 1, which means it's sticky on one side and non-sticky on the other side. This dressing could stay in place for 28 days. You can put medications through it. So for example, pemphigoid. Everybody know what pemphigoid is? And an autoimmune disorder where you get little blisters that pop up all over the body. The more you touch those little blisters, the more dressings that we put on them, the more pop up. So we need to stop the immune system from overreacting, and part of that is stop touching all of those wounds. So fantastic little dressing. If you put that silicone 1 on, then you can put the cortisone over top of it, and it will be absorbed into the tissues and treat those little pemphigoids without having to change those dressings all the time. So nice little thing. Also excellent for skin tears if you don't have this in hand. Some of our affiliated sites don't like the cost of these ones, and so they don't always have those in hand, but they have to have the silicone on because it's in this list, in the second list here. So they can leave that on for 28 days, change the secondary dressing if it's weeping, such as just put gauze over top of it and wrap it and leave that silicone in place for 28 days.
does that work for lacerations too?
Yeah. Yep.
Oh, that's
The
my
acrylic.
That one is micropore is tape. So blue, you know, the blue tape that we put on,
Yeah,
that one's that one. So this one will just be called, a silicone secondary, like a, interface for non-adherent.
second column?
Have to figure it out. It's on the third column.
Which one?
Yeah.
The acrylic dressing.
The acrylic dressing is this one here. And then the silicone, that's the fine is
Border
silicone.
home dressing, is that what-
Yeah, but that's a bordered dressing. This is a non-bordered,
Okay, right here.
non-adherent, contact layer.
Non-adherent contact there with some
This,
met detail.
Mepitel. Yeah. I don't actually see it on here.
It is here.
Is it?
It's like the
Oh, I was looking in the second column. So is it the
Seven.
third one?
seven
Perfect.
month down on the third
Yeah.
column.
Yeah, so that's Mepitel. Mepitel just means that it's sticky on both sides. I just happen to not like that one. I like one that's sticky on one side so that I can put a secondary dressing on the other side.
So when we order it, we just say silicone dressing,
Yeah, silicone non-adherent contact layer.
so.
And we already talked about the triad and the hydrophilic paste. Again, this has a debrider in it. It shouldn't be used on any skincare issues. It should only be used inside of a wound bed. I really like to use it on like coccyx pressure injuries, on ischial tuberosities. You can put a whole lot of paste in there and then cover it with a gauze bordered dressing, which is super cheap. And you can get these tubes that are this big or this big. So again, a lot of our affiliated sites will require a physician's order for this because it comes from the pharmacy. And that actually helps control the use of it. Because of the fact that it does have that debrider in it. I would get them to change that dressing every single day because you're making a soupy mess. That's the whole point. Nurses tend to get upset when they start seeing more exudate. You just have to remind them that's the whole purpose of this, is that we're liquefying the non-viable tissue so that it can be removed out of the wound bed. And then last but not least,
One more question, for silicone's great.
that's okay,
How often do you change that dressing?
every 20 days,
Okay, so it can be left on for 4 weeks.
as long as nurses are dating it,
Okay,
right? So you know, or have it written somewhere when that was on. I always date with a Sharpie and put it on there so that we know when it was placed on. And then we have a petrolatum base. There's two different dressings. There's one called Gelinet and there's one called Adapted. Gelinet is a paraffin dressing, so it's a wax dressing. It's expensive and it has to be changed every single day, which is why I don't like it. I think it's useless. The petrolatum base is fantastic. It's about $1.60 for that larger sheet and it comes with 3 of those sheets in it. So incredibly cheap. It can be left on for 7 days. Great for anything that you, let's say malignant wounds. They should go on malignant wounds or lacerations or anything like that you want to place it on. We often see it on graft sites too. So our antimicrobial dressings that you are going to see in contact with all the time, and again, that are on these 2 lists here, is one is our Bactigras. Bactigras is always cheap and friendly. It is like polysporin with a little bit of petrolatum based into it. It has a 7-day wear time. The only thing is if you have a really, really dry wound, it's going to absorb all of that sooner. So you have to change it twice a week. You just have to be aware of that. Otherwise, it's a mesh that will just stick to your wound bed and you have to pull it off. So again, cheap and friendly, about $2 a sheet. You can cut it and place it into wounds. You can pack it into wounds as long as you don't lose it. I recommend that for anybody that you think might have a culmination of bacteria. Then we have Inidine. Inidine is your very cheap and friendly iodine dressing. I would start with this on all of your lower limb wounds. Anything that's open on the lower limbs and you haven't quite figured out what the etiology of that is, I would start with Inidine because you're not going to harm that wound with it. If you put a moist dressing on there, such as Bactigras, you may actually open that up into a larger wound. So always start with Inidine. Again, $1.50 a sheet, so really inexpensive. Most nurses know how to use it. Next is your PHMB, which is your polyhexamethylene biguanide. It is a chlorhexidine derivative. So really easy to use. Again, comes in ribbon in a 1/4 inch, a 1/2 inch, 1 inch. and then these big, huge gauze, Curlexes. These gauze Curlexes are great for treating intertrigo, so that moisture-associated skin damage in underneath the breast folds, in the armpits, and the groin folds. Because it does have a chlorhexidine in it, we'll pull it in and be bactericidal in that. Has to be changed every day, but is much cheaper than your Interdry or your other wicking dressings that you have for intertrigo.
So that just sticks to the skin.
It's a gauze, so if you put it underneath or you use silicone tape. Yeah, we just sort of place it in there.
Do it still have to be like open wounds there or?
No, that you can use it for skin, yeah. So intertrigo is the moisture-associated skin damage that probably has fungus or bacteria growing in it. And you'll see it by the atypical red ring underneath breast folds and stuff like that.
How often do you change that?
Every day. It has you can change, if you're using it for intertrigo. If you're using it to wrap an entire lower limb, let's say you're worried about cellulitis and it's weeping a ton of fluid, and you just need to have a little bit of antimicrobial in there, I would use that to wrap the lower limb, and then I would change it every 2 to 3 days based on the exudate. And then, of course, our measles. We already talked about this. It does come in the ribbon and it comes in our 4x4 gauze. It comes in a 10x10 too, but we don't often see those ones. And I always remind the nurses that, you know, if you see a great white shark and they've got all these scars, but they never really have a whole lot of wounds on them. Why? Because they swim around in salt water all the time. And this is a nice salt impregnated dressing. It delivers the salt into the wound bed, which is a great antimicrobial. Maybe a little bit of staining in the beginning. This will clean up wounds very, very quickly, especially packing wounds that have a really purulent odor to it. This needs to be changed every single day though. The nurses don't often like that, but sometimes you can't get away from it.
So all those are daily changes, right?
Pardon?
All those are daily changes.
No. Bactigras every 7 days. Inidine is every 3 days. Iodosorb, I didn't go over iodosorb. Iodosorb is every 3 days as well. It is a cadexamer iodine. Cadexamer iodines are the only dressing that we know that can actively kill a biofilm. So if you think that you have a biofilm in the wound, I would go with some iodosorb. It comes in a paste format or it comes in a powder format. The powder is extremely good when you have a highly exudating wound. I don't know why, but it does absorb a ton of fluid. So you can just put that all over the wound. And then the paste, you place it into any kind of cavity. You just have to make sure that you are irrigating that out really, really well, because you do not want that being left in the wound and becoming a foreign body.
But move to the black box.
Yeah. Again, we're going on to our antimicrobials. Now, these ones here are going to be provided by Fraser Health, because it's not ones that are in this columns on here, but it's ones that you're going to see being used. I'm not a huge fan of Ergotool. Ergotool is a mesh that is quite gentle. It's got a 7-day wear. Most of your silvers have a 7-day wear. It is also a non-adherent because it has petrolatum in it, but it's got a very low dose of antimicrobial silver in it. So some people think that it's great, but I, over the years, have not been overly impressed by it. And I've been working with it for about 15 years, so it's okay. It's not great. I like Aquacel Silver, and Aquacel again is a gelling fiber. So if you have a highly exudating wound, or if you need a debriding wound, you can always get this wet, and then you have a gel that is going to go against the wound and promote autolytic debridement. It also has silver in it, so it's a decent antimicrobial. The only one that delivers silver into the wound bed though, and delivers a ton of silver into the wound bed, is your Acticoat Flex. Acticoat Flex comes in an Acticoat Flex 3 or an Acticoat Flex 7. That number tells you how long you can use that dressing for, how long it will deliver that silver into the wound bed. What is special about this dressing is that in the first 30 minutes of activation, which means the exudate of that wound bed is going to pull that silver into the tissues. So even if you have bacteria in the tissues and not just in your exudate, you're going to be treating the surrounding tissues as well. It does stain your tissues black. It does come off as you clean the wound the next time. What's lovely about it as well is you can cut it. So I cut them into spirals and pack them into little tiny tunnels or holes or sinuses. It does sting a little bit when you first use it. So sometimes you have to warn those residents or clients. But other than that, it's a great dressing. I use it on diabetic feet all the time because they get wounds into their web spaces that are highly colonized with bacteria, maybe not infected, but highly colonized. Then we have many honey. What's missing over there is the aconate, and that's because it's on back order, and we haven't been able to get it in a number of months, so I regret. But many honey again comes in a gel format. Unless you're looking to debride a wound, it's not the greatest format, only because it warms up to the body and then melts away. So it becomes a mess, and most often you have to change it earlier. Then you've got the Thera honey. Thera honey is fantastic if you have an abrasion or a skin tear that you're just worried about colonization of bacteria. You may have a little bit of redness around there. You don't want to put them on antibiotics. Put a sheet of Thera honey on there, leave it on there for about 7 days, change it. Great antimicrobial. Honey is fantastic at treating Pseudomonas. So is your PHMB actually. And then your hydrobare blue, again, Venetian violet and methylene blue comes in a nice soft foam. You can see that we often use it around ostomies that have PG or even just are infected because it comes in an ostomy ring. And then it comes in sheets that we can cut up. If the nice feature about this, and same with iodine, is that when all of the antimicrobial is used out of it, it changes color. So this one here starts as that nice brilliant blue. When you've used all of the antimicrobial properties, it's white. So that's when you know you have to change the dressing. Example, yesterday I went into a site and they had hydrochloric blue in the wound bed, which is not something I ordered. I was surprised to see it there. But when I pulled it out, I didn't even recognize what it was. And I said, what kind of foam do you guys have in this wound bed? And sure enough, it was hydrochloric blue, and that's how colonized that little tiny wound was in the coccyx. It was completely white and after 24 hours. So that's a good indicator that that wound is infected, and my very strong antimicrobials are not going to touch that wound. So we needed to get antibiotics on that person right away.
So when you said that goes around the ostomy, and what happens to the ostomy line?
Flange? So this flange here, the ostomy ring that comes from hydrochloric blue has one side that has like a film barrier on it. So that part sticks to the ostomy flange, and then the foam part sits against the patient's skin. So it's got a water resistant barrier on it. So only the fluid from the wound gets absorbed in, and then it goes into the hydrocolloid. But often we don't even use a full ring like that. I cut it into pieces and use it in the areas that are needed.
So there's no barrier for where the ostomy flange is attached. Like you attach it off.
Yep.
The ostomy bag to that. So where is this sitting? It's underneath the flange?
Yes. So it goes directly
So
onto
it
the
seals in the space between the skin and the flange, sealed it.
Yeah, because there's a plastic barrier on one side of that ring that will allow the ostomy flange to stick to it. So the hydrochloric blue sits right against the skin around the ostomy, and then the flange goes right over top of that. But often with ostomies, it's not a whole lot of infection we're dealing with. We're often just dealing with a chemical burn from their leakage, and it's probably going to be plain old powder and spray that we're using. If they have PG though, then we're going to use the hydrochloric blue. Those rings are very expensive. You're looking at like $25 a ring, and you're changing it once a week. But I work at Ostomy Care and Supply Center in Westminster, and we kind of get the worst of the worst ostomy there, so we use it quite a bit. So common wounds, I'm just going to go through the etiologies. Be okay? Okay. Try to figure out which you guys might want to learn a little bit about, and so this is what I get. So stages, I'm hoping that you guys understand the different stages of pressure injuries. This is from the National Pressure Injury Advisory Panel, and we've been using it for years. This is what we teach our nurses to use and how they categorize it. So stage 1 is non-blanchable redness. Stage 2 just goes through the epidermis into the dermis. Stage 3 goes through the epidermis into the adipose tissue. Stage 4 goes into underlying structures. So if it goes down into muscle, tendon, or bone, that is going to be your stage 4. And then we have what's called a non-stageable. That is one that has so much eschar or non-viable tissue that I can't stage it until we debride that out. And then what's really important and what sometimes get missed, and nurses often say they have a bruise on their bottom, is a deep tissue injury. This is a dark purple bruise that you're going to see over top of your bony prominences. It is going to deride down, as you can see, to probably a stage 3 or stage 4. The damage is done really deep down by the time we're seeing it. This tissue is bleeding up into the skin, and that's what we're seeing. Kind of like a diabetic foot ulcer or a diabetic foot callus that turns red or dark purple. We know that that is bleeding underneath that callus. We have to deride it off. We know that this is going to deride down into stage 3 or stage 4. But we want to try and get to it when it's like this. If we can get to it when it's like this and offload that pressure, we can actually reverse this. Once it starts to open on the epithelium, we can't reverse it. It's going to deride all the way down. Lost it again. So these are all my residents. These are just ones that I've seen recently. So pressure injuries, prolonged pressure over a bony prominence or under a medical device. They're usually oval around, red to bluish, non-blanchable redness at first. Pain is absent to severe, comes in all different categories. What's really important for you guys, and I really appreciate it if you would help us out with this, CHI data only collects incidents through physician's diagnosis and reporting. So our CHI data doesn't have anything to do with nurses. So if it is not diagnosed as a pressure injury by our physicians, it doesn't get collected in the CHI data. So that's why we know that CHI data is a little bit unreliable, because often these are not diagnoses, a lot of routine diagnoses. And then overall prevalence is approximately 26% across all healthcare settings, with 70% being preventable. Our economic burden, stages 1 and 2, cost about $2,400 to $3,600 per month, and our stages 3 and 4 cost about $3,600 to $9,000 a month. And when I was talking about a deep tissue injury, so see this dark purple discoloration up top here? This is what this started as. It started as a deep tissue injury, and all it was that dark purple bruising. But very specific is that it's over top of a bony prominence. So treatment options, usually it's not a universal thing. We often use our DIME, which is our debridement, our inflammation or infection. Moisture balance, is it too wet? Is it too dry? And then the last is our edge. And that's when we're looking at closure of the wound. Is the edge nice and even? Is it rolled under? Has it not been packed enough? If the edges are rolled under, we need to cut those edges open to get that wound to close. So it's not a universal treatment for those pressure injuries. You have to look at what the wound is telling you it needs. Any questions about pressure injuries? I've been dealing with them forever. This is our venous ulcers. 80% of our lower leg ulcers are caused by venous insufficiency, located between the knee and the ankle. Knee and ankle. Shallow with irregular margins, surrounded by dry, flaky lipodermal fibrotic tissue, should have palpable pulses. If they don't have palpable pulses, then you probably have a mixed etiology with arterial insufficiency. And then swelling of the tissues and serous drainage, you're going to have a whole lot of that. Gold standard for venous treatment is compression. So that's what we always want to start at. Nurses can start compression without a physician's order. They can start it in light. So anywhere between 8 to 20 should be started right away. Then if you want something higher than that, you can get an ABPI or a TBPI, that's what an angle brachial pressure index is. Anything that you want to order that's from 20 to 40 to 50 needs to have an ABPI or TBI done, and MCISc can do that. So you can bring one of us in, get a referral, and we'll come in and do that for you, and then recommend the compression based on your TBI at the bedside. What we have.
I just had the carriers came by and wanted ankle brachial pressures done for me to refer off, but you just do that yourself?
So I can. Most MCIScs can. The only thing that I would assume that they couldn't do is if they couldn't get it, they tried and couldn't get it, then they want it to go to a vascular surgeon.
No, they didn't say that. They said I should refer to the vascular surgery, so. But,
Well, at least in long-term care.
It probably would have been better for them to actually call me, talk to me about it.
Probably. In long-term care, if you have funded residents, the three of us that work in, for Fraser Health, all have a TBI machine in our cars all the time. So they're with us all the time, so we can do them at any point. And they're pretty fast for us. We have really good machines, so they take us about 20 minutes to do. And then we have, edema-aware and tubing grip, which again is on this list in the first two columns. So the long-term care sites should have them in hand and on stock, and you can start them at any point. The only time you don't start compression right away is if you're suspecting infection, and then you wait until it's 3 or 4 days into the treatment of that infection, and then you start the compression. But you always start the compression as soon as you possibly can. The best thing to do for your venous ulcers for treatment would be your iodine dressing. It is cheap, it's gonna dry it up, and it's gonna help improve it. It is an antiseptic and it is quite strong. It's because it's so cheap, if there's got a lot of weeping going on while you're still quite acutely infected, you can change that every day. Once that starts going down, you increase that or decrease the frequency and change it every 2 or 3 days, based on whatever your needs are.
If they have an allergy to iodine, what do you recommend?
Even if they have an allergy to iodine, it's usually not a true allergy. It is a false allergy. But if they have an allergy to iodine, then I would use chlorhexidine, so Bactiguard. It would not be my preference. But then I would also suggest that instead of cleaning with just plain normal saline, that you would clean with 2% chlorhexidine and with 70% isopropyl. But you're gonna dry it up. You need to dry up those vascular wounds, right? These venous insufficiency wounds. And that's the iodine and the chlorhexidine are gonna do that. Arterial wounds, again, something we see all the time. So arterial insufficiency, where blood flow through arteries is reduced or blocked, located on the feet and lower legs, typically the feet, toes, heels, and ankles. As you know, we see them on the inner and outer malleoluses all the time, and we see them in the little areas on the tops of the toes, little micro perforations there. The skin is going to be shiny, pale, hairless, and cool to the touch. The wounds are very dramatically round, or you take out an entire toe like this one here. They don't have diffuse edges. That's the difference between the venous and the arterial, is that they do have a nice punched out look to them. Absences are, or pulses are absent or diminished. And then compression can be used in mild cases, but nothing more than light compression. And this is where, when we look at our TBIs and our ABPIs, we're looking at ruling out arterial insufficiency, not actually determining whether or not they have venous insufficiency. This is what we really care about. Because you guys know that in venous insufficiency, it's our calf muscle pump and the valves that are failing, right? So that's why we need the compression on there to get that back. So treatment options for this is, the goal is to create a dry, stable eschar. Keep the wound dry, reduce the bacterial burdens, do not add creams, lotions, or ointments. Fusidin is one of those detrimental ones that we see ordered for these arterial wounds, and it creates a mucky mess. We end up with infection even with the Fusidin. Do not soak the feet or the wounds. We do not wash arterial wounds with normal saline. We only wash them with povidone iodine. Again, if they have an allergy to povidone iodine, then we will use the chlorhexidine, the 2% chlorhexidine with the 70% isopropyl. Again, very cheap to bring in, or the betadine, which is 0.05%. And our primary dressings, moisture absorption, dry, inidine, or iodosorb is what they can see. Should be ordered for these right away. And never ever use foam on arterial wounds. As a rule of thumb, I tell nurses, do not use foam on anything ankle below, because of the fact that it's moisture retentive. And if you don't know the etiology, if you don't know if it's arterial or if it's pressure or if it's diabetic, you are risking them getting an infection by holding that moisture against their wounds. So always use a dry dressing such as a Mepor or an ABD pad or a Mezor.
How does it heal when there's eschar on top?
It slowly heals underneath. So it's like creating its own natural bandage. What's concerning is if you start to see moisture seep out from around the edges, then that whole eschar needs to be lifted off. Even though we think that that's the wrong thing to do, once we see moisture underneath there, there's bacteria underneath there. We have to pull it off and start treating inside. But the goal is to have it dry and stable, and it will sometimes slowly heal underneath. But if there's not enough blood flow, it's the body's own bandage underneath there. And if they have a nice stable eschar on their heels or their toes, I get super excited. But what we have to remind the nurses that even with bathing, we have to keep those dry and out of tubs and out of showers. We have to bag those legs. Diabetic foot ulcers. This for some reason became like one of my specialties. I'm not really sure why, but it did. I don't particularly love wound care. I love ostomies, but I'm good at wound care, so that's what we do. Poor circulation and diabetic neuropathy located on the pressure points of the feet or the ankle may start as a small cut or wound and progress unnoticed to a round ulcer and with even edges, usually most of the time. Pain is often described as pins and needles, or there's none at all because they have a loss of protective sensation. And then you're going to look for the sensory, the autonomic, and the motor neuropathy. And each one of those different things will give you a little bit of clue about how progressive their diabetic what is going to be. We will grade to this. Lost it again. I did. So if you have an MCISc involved, you'll usually see us grading with the Texas University Diabetic Ulcer System. And that really gives us an indication at how concerning this wound is. If we're down here with a stage D with infection and ischemia, we're probably going to want to refer it to a vascular surgeon if they're willing to do that, because we want to try and increase that blood flow. Otherwise, they're looking at a loss of limb if it's being graded at a D grade. Often what we see is wounds at a B2 or B3. By the time they come to us MCISc, we would love to see them sooner than that. We can get diabetic ulcers, but ulcers closed in long-term care. Just had one closed not that long ago. Usually takes really good control of the blood sugars, between a 4 and a 6, which is very good control. And we have
to be between 4 and
no,
6.
the daily blood sugars. Yeah. Because of the fact that the blood flow all the way down, we can't get control if you're seeing 8s and 9s. We can't get control of that wound. They get infected over and over and over again. And then we have to offload the pressure. Often the foot is being, there's trauma that's going from the foot. We see a lot of people that don't walk, but they scoot around on their wheelchairs, or they just sit in their wheelchairs, and then those wheelchairs have those hard bases on the foot pedals. And that's where we see those pressure injuries from. Primary dressing really depends on what the concern is. You're probably always going to want an antimicrobial on a diabetic foot ulcer. You can use the Aquacel AG. Like I said, I happen to like Acticoat Flex because a lot of times you're going to be packing in between the web spaces or wrapping a toe with a type of antimicrobial. So that one's really good. For anything that has ischemia involved, so if you're grading your ulcer and you've got infection and ischemia or just ischemia, then you're going to go with the ND or the iodosorb. And then if there's no big concerns, no concerns depends on majority of tissue in the wound bed. I don't know what I was trying to say. So we can actually create a lot of our own padding offloading. So MCISc, again, we carry this cast padding in our kits, and we will cut it out and then offload it so that we can get these to heal. You can get these little wedge sandals, but not really safe for your gaits. What's really great is that Darko has what's called a Pegasus, and it's an insert that you can get put into the shoes, and you just pull out the little pegs where that diabetic foot ulcer is, so that if they step on it or even put their foot on the wheelchair, there's actually a space where the wound is, and the other pegs surrounding it is taking up that weight.
I have a question about the blood sugar. You said that the fasting blood sugar goal is between 4 and 6?
Mm-hmm. Yep.
Because usually with the
elderly patients, they recommend not to go too low.
Yep.
Is that different when it comes to them having?
And diabetic foot ulcer, yes it is. Yeah, and this is from Diabetes Canada. If you look up your documents on foot care.
Are they looking at that for people in long-term care though? Part of their
Yeah.
population?
If the goal is to heal it, right? So if the goal is to heal it with our populations, if the goal is not gonna heal it, then we don't worry about blood sugars.
The fellow I was talking with, they said it's like probably maybe almost 50 years old and he's got diabetes on his son. And he's got a spinal cord injury.
Yeah.
But interestingly, he has a little hissy fits. It doesn't necessarily for food. So the problem is sometimes he's not eating and other times he's eating. So his sugars drop from like 2.5 and then go up to 18. It depends on what he's doing. You can't hard to adjust his insulin.
Oh, I know. It's hard to get them to understand the importance of the correlation of the blood sugars to the wound and the risk of loss of limb. Even with people that have already lost the lower limb and then their next leg goes and they still can't get them off of that Coca-Cola. So then skin cares, so this is just a variety of skin cares that I've seen in the last little while. Traumatic wound that affects only the dermis and epidermis can be caused by shearing, friction, or blunt force. Can occur during activities like transfers, falls, or removal of adhesive dressings. Usually it occurs in the fragile, dehydrated, malnourished skin at a higher risk. And our only thing is we do not apply steri strips or any kind of adhesives, such as suturing.
How did that came to the outbreak?
This one,
Yeah.
that was a whole shear force from a wheelchair.
Oh,
So again, we talked a little bit about the gold standard for skin care in Fraser Health. And these are some of the things that we see. Acrylic dressings are really helpful for these skin tears as long as they're not actively bleeding and not a huge amount of exudate. If you do have active bleeding or you have a lot of exudate, I would just go to either your Bactiguard, your Meptil, or your Daptic. And then of course you have your Ergo Tool, which has a little bit of antimicrobial in it. So cost wise, just so you guys understand the cost for the affiliated sites or even the owned and operated, again, $1.50, $6, $1.25, $12.50 per sheet, not box, that's per sheet. So huge costs. This one can be worn for 7 days. Meptil one can be worn for 28 days. Adaptic can be worn for 7 and Ergo Tool AG can be worn for 7 days. So big difference in cost, but usually about the same effectiveness if you can get them on. Malignancies. So the goals of care are often different per resident because of the fact that you're looking at, we can't treat this, we just have to go with what their concerns are. Often it's odor management, bacterial management, pain control, or control of bleeding. The treatment options for control of bleeding, I always recommend the tranexamic acid. Comes in a powder format and you can mix it with flagyl as well as morphine or methadone powder. And that can be your primary dressing for these wounds. Gives them a lot of comfort. The other piece that you can use is Keltistat. So that is our calcium alginate. Again, it is seaweed, so it is a nice gentle dressing. But you do have to remove it. So if this is really painful for the resident, I wouldn't use a dressing. I just use the powder with the flagyl and the methadone or morphine powder that's in it. I say powder because that's what I'm used to when there's a moist wound. You can also do it in a gel format as well. In the hospital, we often use the tranexamic acid in these big IV bags and just pour it non-stop irrigation into a bleeding wound. Odor control, we have Octadorb. It's really one of the only things dressing wise that we can do. I often recommend cat litter underneath the bed or old coffee grinds, and a lot of our residential care sites or long-term care sites, they have coffee houses, and you can use old coffee grinds and put it underneath the bed. Will absorb a ton of their odor that is coming from their wound. These little guys here, they're okay. They stick to wound beds sometimes, but again, they're about $15 a piece, and they're only 10 by 10s. And then if there's too much exudate, then it deactivates the charcoal and they no longer absorb the odor. So this depends on what your site is willing to bring in. I can't say that a lot of sites are going to be willing to bring this one in. And then your bacterial management, you've got your Bactiguard, again, cheap, friendly, easy to use on those malignant wounds, non-adherent. You also have your collagen powder, comes in a cream, and you can also put it in a spray. And then pain control, morphine powder spray or cream, lidocaine gel, and then the methadone. And as long as you guys are ordering it, the nurses can apply it. And then moisture associated skin damage. Most common is incontinence associated dermatitis, inflammation of the skin due to repeated exposure of urine and feces. It's plain and simple. If infected, try and not add more lotions and creams to it. Like I said, today I saw a gentleman, he had a secondary infection of both bacteria and fungus as far as I thought. And then they ordered Houston to be applied on it, but it's already moisture associated skin damage, and we're adding more moisture to it. So we would prefer to see creams such as our zinc oxides that are in the higher percentages at the 18 or above, which most of your long-term care sites should have already on hand. And it increases the risk of developing a pressure injury about 50%. So we really want to get this healed up. I strongly encourage the use of condom catheters or external male catheters. I'm not one that's going to ever tell you to put a Foley catheter in somebody, because we do have other devices, both for women, we have PureWick, and we have condom catheters for men that can help manage that moisture associated skin damage. I also am a big advocate for getting the bowel movements controlled, either by using enemas or by using suppositories or by using Imodium, any kind of control that we can. Imodium is great because if you have diarrhea, it's in your system for 4 hours and you just kind of put it on top of it. We use Imodium all the time in diarrhea in an ileostomy, and yet we don't use it in our residents that have moisture associated skin damage that has a lot of fecal enzymes in it. So we really should get control of those bowel movements, so the caries have a little bit more knowledge of when those bowel movements might be occurring. So most of the day, those residents can go without stool on their skin, which is almost more damaging than the urine is. So treatment options, a lot of our sites, our affiliated sites are, they have a vendor, which is Medline, and so you're gonna see the Remedy skincare line. So this is what every single resident that is in a diaper should be having put on their skin 4 to 6 times a day, is the silicone or the dimethicone cream. And I tell nurses all the time, you cannot put too much of this on a person that is incontinent. If you put silicone cream on a piece of paper, one side, don't put it on, and the other side, put it on top of the piece of paper, and you put water on top, it will completely bead off that paper. That's what we want it to do to those residents' skin. We want the urine to bead off their skin. And that's what that's going to do. But it comes down to, it's telling the caries to put it on. Sometimes we have to write those directives because they just don't do it intuitively. And then to treat it, you really want the zinc oxide at 18 to 30%. This one here is the extra protective cream by Smith & Nephew, and it is 30%, which is the highest one on the market. If we have severe moisture associated skin damage, there's lots of openings on the skin, then we're going to even go away from the creams and go to a what's called an Cavalon Advance. And it is an acrylic liquid that we actually paint onto the skin. That will allow nothing to be put onto the skin, no creams, no lotions go on top of that. It will protect the skin for about 2 days from the urine and feces. So it's really strong, really good, and then it will just naturally pull off. This one here is provided by Fraser Health. So if you think that your resident has severe moisture associated skin damage, please bring one of us in. Those ones are about $10, but they work. Usually in about 3 to 4 weeks, we can have that moisture associated skin damage completely healed up. Really importantly, remove those cloth soaker pads. We know research-based, they increase moisture associated skin damage by 3.2 times. And then they increase the risk of a pressure injury by 1.9 times. So huge amounts of risk with the cloth ones. If you want to have something underneath a resident, you can use the disposable incontinence pads, which actually hold up to 3 liters of fluid. So you don't need to have those cloth soaker pads. Get rid of them.
There are many places I don't really recall.
They're in everywhere.
They're I've
Yeah.
had them in my home.
They're green. They're green soaker pads that go underneath almost every resident. I would throw them all in the garbage if I could. Oh, we have contracts.
I'm sorry, this This 18 to 20% zinc oxide, is that provided by Fraser Health? Because I'm having to order that at my sites.
So, no, but it is, so. Is it affiliated or owned and operated? If it's affiliated, it's on this column here and they have to provide it. So they don't have to provide the extra protective cream, but they have to provide another zinc oxide that is about 18%. So the remedy line, which is what they're both gonna have, so then you can tell them and give them this and say they have to provide it. It's part of the Ministry of Health requirements to treat incontinent-associated dermatitis. So they have to provide it.
I think the issue is that the owners of the facility are wanting us to order it because then the patient is
Has to
to order it.
Yeah. But it's requirement, this is a licensing requirement?
Yeah. Yeah, they have to have it in. Okay, the other part is change your briefs more frequently. And then also I would suggest using underwear liners as opposed to full diapers. And then condom catheters for men. We can get those on them. I would absolutely recommend those. And I know that there is this myth around there that it increases the risk of urinary tract infection. That is not condom catheters. There's no research that says that that occurs. So this is just our resources that we have. Connecting Learners with Knowledge is the CLIC website. So that is what's actually maintained by us Provincial Nursing Skin and Wound Committee. Every single product that we have that is available in BC has a product information sheet in there. So it tells you how to use it and why you're using it, and also the contraindications. And then MCISc Canada, which is my association for all of us nurses specialized in wound incontinence. We write a lot of the DSTs or the clinical decision support tools, and you can look especially for like condom catheters and all of those other things. Wounds Canada also has it, and then your two other national advisory panels, which is the Canadian Pressure Injury Advisory Panel. Again, best practice recommendations are on there. And then your International Skin Care Advisory Panel. Again, your best practice recommendations. The wound clinicians and long-term care have written an app, which is very, very helpful for nurses. It takes our dressing selection guide provincially and put it into an app. So the nurses can say, this is what my wound bed looks like. And we give them directions on how to care for that wound. So they can download this app and get treatment options free.
What about it?
You can download it and use it too. It's why it's up
I
there.
didn't know the winter stuff was in.
So it is, so first line has two different ones. It has the antimicrobial stewardship, and then this one here is the wound care one. But yeah, it will give you,
First line critical decision.
yeah,
So you just did first line clinical decisions and we'll be able to find them out the app. So
yeah, so if you, yeah, or you just put this camera up to your QR, you can get it that way too. The QR code does link you to that app.
But is it the ID? Because we have the first, it's called the first line for the ID. Infectious disease.
Yeah, it'll come up with just your wound care. It'll come up directly into the wound care one for this QR code. So you have 3 different first line apps because that's what Fraser Health is contracted to. Also, if I don't know if you have access to the Pulse and Fraser Health, this is linked to those little libraries as well. It's linked there, so you can go straight into there. But yeah, you can create any wound care plan based on not even the etiology, just based on what the majority of your wound bed is, because we're not asking the nurses to diagnose what it is. We're just asking them to create a treatment plan based on what they're looking at right then and there. And it gives them how to clean it and everything else. That's it.
So, seeing as there's someone gets involved with the SFU, I think, wouldn't it just be like a couple lectures a year?
Yeah,
The students are going through, or, because they're gearing it for family practice, right?
Yeah, and you guys don't get enough wound care.
Get enough,
Nurses don't either. They learn how to take care of surgical wounds and that's it, right?
Yeah.
So every
I just
education
think
that nurses
you
get.
haven't heard anything from SFU or anything interesting, but
I mean, there's so many of us Xbox out there. You can definitely ask any of us and we'd be happy to give
that should be
education.
part of their regular training. Like educating the students. Sort of.
yeah.
And if you have any nurses or if you have physicians that want to take education, that's more than this as well. Fraser Health provides free courses. The nurses can sign up on the Learning Hub, which will know what that is. And I'm teaching tomorrow, it's a 4-hour virtual class on all of this stuff as well. And then we also do in-person lessons as well.
More research and all that. I want to give an opportunity to the folks online to see if anyone has any questions. For those of you who are joining online, please feel free to just unmute yourself. Do you have any questions for Misty? Anybody else in the room? No, thank you so much.
Thanks for having me.
Fantastic.
You know, email me or whatever.